Welcome to our short lecture on pain in the older adult. This is just an introduction to pain and pain management. You're going to be covering pain mechanisms and treatment at a much greater depth and length in your pain class with Dr. Bement that occurs during the DPT 5 spring semester. Pain can come from a variety of sources. When we look at the research that's specific to older adults, we see a variety of diagnoses that can be sources of pain. Joint dysfunctions like DJD, stenosis, or fractures are going to elicit pain ratings at a variety of body locations. We have systemic and internal conditions like urinary retention, infections, neuralgia, gout. Will all cause specific pain referral patterns that as physical therapists we need to consider as they will impact our overall treatment and plan of care. We need to consider the high prevalence of pain in older adults. Research states that 25 to 38% of community dwelling older adults and 49 to 83% of nursing home and long-term care residents report pain. Now, although pain is commonly reported, it should not be considered a normal part of aging. This increased pain can result in decreased socialization, decreased and impaired ambulation and function, and ultimately an increase in healthcare utilization. Now, there's a lot of other consequences of increased pain that can include depression, anxiety, falls, malnutrition, reduced cognition due to impaired sleep, again, functional disturbances. And unfortunately, there's a significant undertreatment of pain in older adults, and that is often the case for such a high impact on pain reports in the older adults. Now, just a little bit of information about medications. Acetaminophen or Tylenol is the most prescribed often, but we know I can look back at research specifically to older adults. And for example, a research study found that nursing home residents with cancer, only 38% of those residents complained of pain, and only 26% of those received, actually, 26% of that 38% did not receive any sort of addressment of that pain. Also, we can look at research studies that look at cognitively impaired nursing home residents, and 60% of those residents at least had one diagnosis that's known to cause pain. No pain medication was given to any of these individuals within the previous month. We can look at community dwelling older adult statistics as well. 47 to 80% of those community dwelling older adults do not receive any treatment from pain. So pain is really a big thing that we need to address and make sure that we are constantly assessing with our older adult population. Again, pain is not a part of the aging process. I can read this quote here from a doctor way back in 2001 that states, "The major practical and clinical concern may well be not whether the loss of pain perception occurs with otherwise normal aging, but rather that considerable unnecessary suffering occurs from undertreatment of pain in the old." Now, that pain in the older adult really has to consider the proper use of conservative interventions for pain control. This can lessen the need for medications. It may allow postponement of potential surgeries, but again, the research states sadly that conservative non-pharmacologic interventions are not often used in the management of some diagnoses that are associated with pain. So how do we assess pain? We can look at and address, think about what is the process of pain assessment. First, the individual, of course, is going to self-report that pain to a variety of individuals. Then as a medical professionals are going to come in and analyze the pain report. They're going to try to determine potential sources of that pain. What is the cause of the pain? Can we address the cause of the pain first. We're also going to observe patient behaviors, right? Observe the patient through all tasks, address the family, see what the family reports in terms of the changes of pain. And ultimately, medically, right, we want to address and attempt analgesic trials if it's needed, but really address those non-pharmacological interventions that could have some really positive impacts with our older adults. When we're taking a pain report in therapy specifically, you want to start with simple questions. Allow the person appropriate time to reply and respond. Consider all of the information that we reviewed last week when it comes to communication changes, right? Simple questions. Do you have any pain or are you in pain? Where is the location? How long has it been? If the person does not communicate well, then we might need to determine or utilize different pain scales or different key findings like hand grasp, or do they blank, or visual, changes in vision and or body language to kind of assess where pain might be. So pain scales are the gold standard, and we'll talk about that in the next slide. Self-report of pain is the gold standard of pain management assessment. However, in many clinical circumstances with older adults, such as those individuals who have cognitive impairments, the patient's verbal response might be unobtainable. So it necessitates the utilization of estimates and or utilization of other scales. So the visual analog scale is one we normally utilize, but the FACES scale can be utilized here. And we can look at studies that show that 86% of nursing home residents can complete at least one of these pain scales. Again, the visual analog scale doesn't replace a physical exam or medical history or interview, but it can assess with determining whether the key pieces that you're working on or the things that you're trying for pain has improved. You also have some information in your notes about the pain rating scale, and there's another scale called the Pain AD, that looks at pain assessment specifically for nonverbal individuals with Alzheimer's dementia. Behavior observation is very important when it comes to pain management assessment. Not only are we going to ask questions, we're also going to observe the individual for behavioral indicators of pain that they may or may not be reporting. So during movement and at rest, are there any is there guarding? Is there a decrease in movement, a decrease in range of motion? We're going to note changes in unusual activities with behavior. Sometimes pain with older adults, especially either with dementia or that are unable to communicate, will increase anxiety and or increase movement, restlessness for older adults. Or it can also decrease overall mobility. You can see a decline in the person's movement because they don't want to move due to that pain. I mentioned facial grimacing and how important that is in that observation. That facial changes and or body language changes can be the most frequently observed behavior in cognitively impaired older adults. But the behaviors are not specific to pain intensity overall, and a change in behavior could reflect physiological and or emotional distress. So here's a quick checkpoint for you. I want you guys to tell me which statement is false. So we're going to do a true or false. True or false? Assistive devices can limit forces that stimulate pain. That is true. Adverse effects of assistive device use include skin breakdown and weakening of muscles. That is also true. Devices include walkers, orthotics, and spinal braces. And that is also true. So last thing, there is no need to fit devices for short-term use. And that one is false, and we'll discuss that here. Now, intervention for pain. Let's start talking about assistive devices. There are a variety of devices. Devices are not just canes and walkers that you guys are used to. There's a lot of different things out there that can be utilized, and I just have a very few number of them here. So assistive devices limit mechanical forces that stimulate pain at the site of pathology, trauma, and inflammation. So they absorb impact, they change or decrease the amount of pressure in a particular joint. Things like shoes, foot orthotics, orthoses can limit those forces in the lower extremity. We have a few pictures here of some spinal braces. So these might be specific to spinal pathologies and or osteoporosis. So the Jewett brace, which is down in the bottom right-hand corner, and the Cash brace, which is down in the lower left-hand corner. These are two braces that are utilized specifically for thoracic fractures to limit an individual's ability to go into flexion, keep them in an extended position, and ultimately decrease those forces in the anterior part of the vertebral bodies. And it also decreases pain. You have a TLSO brace at the top right part that looks at completely supports the spine. And again, that's to maintain postural stability and decrease vertebral force compression. Now, we have to also consider the adverse effects of some of these assistive devices. It could lead to skin breakdown. It could lead to psychological dependency. Ultimately, you want to remove some of these devices if they're no longer needed. But people might get used to wearing them, right? And wearing them for an extended period of time could potentially weaken the muscles whose actions has been limited. So as therapists, we really need to consider how to safely maintain appropriate muscle strength while maintaining appropriate posture and appropriate positioning of that patient. So that proper evaluation, it needs to include appropriate selection, making sure that items fit along with either short-term use and or long-term use devices, right? That is warranted to prevent further complications for our older adults. Now, therapeutic agents could also be utilized. You will discuss therapeutic agents at length this summer with Dr. Starsky, but things like manual therapy, massage, soft tissue mobilization can be considered to address some pain management. There's very limited studies when it comes to the overall long-term benefits of utilizing these agents for managing long-term pain with older adults, but we also have to consider that sometimes that short-term effect is beneficial to patient buy-in. So with older adults, we have to remember the person might require special positioning due to medical conditions, due to potential deformities. Somebody like this individual here that might have an increased amount of kyphosis, they might have some that you might need to get them into a prone position, but can you do that? Can you get them sideline? Can you get them supine? The answer is yes. You just have to modify the positions. You have to make sure you have appropriate support, appropriate pillows. You might need to raise the head of the bed or utilize some incline mats, etc., to really help the patient get into a comfortable position prior to your manual therapy techniques. E-stim is another technique. Again, you're going to discuss this at length with Dr. Starsky, so I'm not going through the specifics of E-stim, but just remember when it comes to the older adult population, go back to our lecture a couple weeks ago about the skin changes that happen, not just with skin, a decrease in skin, but a decrease in those corpuscles that can feel thermal responses. So there's an increased incidence of dry skin in that aged adult that can result in dermatitis if you're utilizing electrical stimulation. So dry skin can actually increase the resistance of the flow to a current. So it might require an increase in intensity of that stimulation. So just being very careful, utilizing more electrode gel, potential water to decrease the resistance, alternating electrode placements. Don't use the same electrode placement back to back. When you're removing electrodes, you really need to be careful, right? Hold down the underlying skin when removing that electrodes and removing those electrodes slowly and carefully. And considering some of the changes with older adults, things like pacemakers or internal stimulation devices, utilization of electrical stimulation in certain regions might be contraindicated. Thermal agents could also be utilized, but again, there could be an increased risk of injury. Now, this is, I'm looking at a study specifically to osteoarthritis, but it could be incorporated into absolutely every diagnosis. We talked about a decrease in hypothalamic thermoregulatory system reactivity. That's a big word, but basically there's a change in how an older adult's body can react to thermal agents. So the key piece, there's a decrease in perception of those thermal agents. There's also medications that can impair with thermal regulatory control. Think back to pharmacology. Medications like vasodilators could be hampered by diuretics, which will limit volume expansion. Anticholinergic drugs could impair sweating. So all these things need to be considered if we're thinking of utilizing thermal agents with our plan of care for older adults. Deep heat should be avoided if possible, or just be very careful. You want to use definitely lower temperatures for heating agents, higher temperatures for cooling agents. Produce slower rates, right? Older adults can produce slower rates of temperature change. So you want to shorten the time for the superficial heating agents. And you also need to continually check, right? Continually check the skin. Really, there's a very much a lack of evidence in the utilization of thermal agents when it comes to pain management. So for us as therapists, it causes us to really utilize a general common sense when it comes to this area of pain control and pain management. Now, exercise. Here's another checkpoint for you. This is really important. Just think of, remember the little dancing sun in here. Exercise is the category that has the most studies and has the most direct effect on pain management. So exercise increased inputs on joint mechanical receptors. It provides indirect effects that are related to an increase in blood flow. Again, it disperses chemical depolarizing and sensitizing agents. So exercise can decrease edema. It can inhibit muscle spasms and or fatigue muscle spasms for an elimination of that muscle spasm. It enhances range of motion, it enhances flexibility, it enhances strength, endurance, and ultimately in turn that's going to increase relaxation and decrease anxiety for our older adults. So keep this in mind. Exercise should not be viewed as a one-time rehab intervention. So we have to always remind our patients, okay, this exercise needs to be done in a continual basis to see a buildup of effect and a decrease in pain. Now, some activities can occasionally increase pain. And so part of our education with our patients is also to discuss the fact that it might increase your pain a little bit, but that's going to be a different sort of pain, right? It's not a harmful pain. It's not going to cause you harm. Ultimately, it will decrease your pain and will be beneficial. So these are just some standard precautions that we have to address with all of our older adults when it comes to exercise. So again, based on the studies to date, the best support exists for the use of therapeutic exercise for conservative management in that older adult population. Thank you.